Rilpivirine LA, to be administered with cabotegravir LA, is available as a monthly or every 2-month dosing regimen for the treatment of HIV. The efficacy and safety of these regimens has been shown in phase 3 studies. Women that became pregnant during the studies discontinued IM study drug, switched to an alternative antiretroviral regimen, and entered a 12-month long-term follow-up, as did other participants that discontinued study drug for other reasons. This presentation focuses on available rilpivirine PK data for women during that long-term follow-up to characterize the PK tail. For the present analysis, rilpivirine PK tail data were available for 3 women that became pregnant while on IM treatment and subsequently had a live birth. Their plasma concentrations are presented in color in the current figure. Data presented in gray here is for 4 women that discontinued IM treatment while not being pregnant. Overall, the rilpivirine PK tail concentrations are in similar range for pregnant and non-pregnant women. The absolute level of the rilpivirine plasma concentrations at the end of treatment and during the PK tail would, however, depend on the length of prior exposure to rilpivirine long-acting, so the number of prior injections that these women had. In addition, it can also be influenced by the alternative ARV regimen that the women switched to. We looked at that in some more detail for the 3 pregnant women. In the following graphs, the black line and shaded area represent the median and 90% prediction interval of population PK model predicted rilpivirine concentrations over time after discontinuing rilpivirine long-acting injections, and this is based on assumptions for 1,000 women. The observed data for the pregnant woman are presented in circles, and the red line represents the model predicted tail PK for that particular woman, irrespective of which alternative antiretroviral regimen she is taken at the time. This particular woman, number 3 in the poster table, was at steady state when becoming pregnant, with 176 weeks of prior exposure and a rilpivirine concentration of about 200 nanograms per ml at that time. She switched to a dolutegravir-based regimen, which would not be expected to impact her rilpivirine concentrations during the PK tail. And as you can see in the graph, her rilpivirine concentrations over time decline in line with the expectations for other women with a similar prior exposure to rilpivirine. In the second case, prior exposure to rilpivirine LA at discontinuation was 16 weeks, and the rilpivirine concentration for this woman at that time was around 75 nanograms per ml. This woman switched to a boosted darunavir-based regimen during long-term follow-up, and as that is a CYP3A inhibitor, it would have increased her rilpivirine concentrations during the PK tail. The observed values, in comparison with those predicted for women on a CYP3A inhibitor after discontinuing rilpivirine LA, are presented in the right panel. In this third case, prior exposure to rilpivirine LA was 32 weeks, and the rilpivirine concentration at that time was about 90 nanograms per ml. This woman switched to an efavirenz-based regimen during long-term follow-up, and as that is a CYP3A inducer, it would have decreased her rilpivirine plasma concentrations. And indeed, as you can see in the right panel, the observed concentrations are more in line with what is to be expected for women that are on a CYP3A inducer during long-term follow-up. In conclusion, pre-pregnancy rilpivirine concentrations for women in this analysis who became pregnant while on IM treatment were consistent with relevant population estimates for women with the same prior exposure. Although current data do not permit a full assessment of the physiological effect of pregnancy on the plasma PK of rilpivirine after IM administration, plasma rilpivirine concentrations during the PK tail were similar for pregnant and non-pregnant women who discontinued LA. Thank you for your attention.